Besides being a mu agonist, why is methadone clinically useful? Choice A, it does not have the immunosuppressive actions of other mu agonists. Choice B, it stabilizes the cardiac QT interval. C, it is an NMDA receptor antagonist. D, it minimizes drug-drug interactions. E, it is highly predictable in its dose-equivalent relationship with other opioids. The answer is it is an NMDA receptor antagonist. That is the reason that we might use methadone in a pain setting over other opioids. There, in fact, is no evidence that it is less immunosuppressive. It prolongs rather than stabilizes the QT interval. It has more drug-drug interactions than other opioids, and its dose equivalence with other opioids varies greatly with the level of tolerance. So methadone, it's naturally long-acting. Almost all the others are in a slow-release format. Methadone just is naturally a long-acting drug, highly bioavailable at 80%, extensively metabolized by different enzymes in the cytochrome P450 system, no active metabolites. The L isomer is the opioid or mu agonist. The D isomer antagonizes the NMDA receptor and inhibits reuptake of serotonin and norepi. These make it more useful for chronic pain, maybe particularly neuropathic pain. But it does have special risks. A big special risk is that its dose equivalent changes with how tolerant your patient is. And so if you have a patient that's on hydrocodone, 5 milligrams, 3 times a day, 15 milligrams, you could safely say, well, methadone is going to be roughly twice as strong, so I should give between 5 and 10 milligrams a day, and you're going to be okay. But, so here I use a case of a patient on 30 milligrams a day. The methadone equivalence would be 15, roughly twice as strong. If you have a patient that is getting 600 milligrams a day, and you use that same 2-to-1 ratio and put them on 300 of methadone, you're going to have a dead patient. Because the more tolerant they are, and anybody on 600 of morphine a day is highly tolerant, the more potent methadone is, and instead of a 2-to-1 ratio, it can be all the way to a 20-to-1 ratio. And so the way this patient would have to be handled is he'd have to do it in stages. So typically you would leave him on about 400 of morphine, you take 200, and convert that, maybe using a 20-to-1 ratio, so maybe put him on 10 of methadone, and see how they do. And a week later, a month later, do another 200, and a week or a month later, do the last 200, and they will probably end up in this range. So why would that be? Why would it change with tolerance? The reason is because methadone undoes tolerance. Methadone binds to the NMDA receptor, and the NMDA receptor is part of the mechanism behind tolerance. By blocking that receptor, you're blocking tolerance. And so the patient who is tolerant at 600 of morphine, when you switch him to methadone, he's going to lose a lot of that tolerance. And so now you have to give him doses like a much less tolerant patient. Other special methadone issues. It prolongs the QT interval. So you might think about getting an EKG. Generally, you would get an EKG at doses above 30 milligrams a day. If the patient is on any other QT prolonging drugs, if the patient is older than 45 years old or even younger but has cardiac risk factors. In all of these scenarios, consider getting a repeat EKG after you're on methadone to make sure that you haven't changed the patient's QT interval by the addition of the methadone. It has a long half-life, so you want to really avoid any rapid dose adjustments. And you want to probably avoid it in elderly patients because of that long half-life. Lots and lots of drug interactions. So let's take a few looks at them. Methadone levels can be reduced by some of the anti-seizure types of drugs. It can be increased by a variety of antidepressants. Tricyclics are particularly concerning because tricyclics will increase, the methadone will increase the tricyclic blood level, and the tricyclic will increase the methadone blood level. So both blood levels are going up. Both of these are QT prolonging drugs. So both levels are going up, and QT interval is going longer, which puts the patient at high risk. Okay, let's switch topics a little bit. Let's talk about sleep apnea. This is now across all opioids, not talking about methadone anymore. An observational study of 140 chronic pain patients getting stable doses of opioids were tested with polysomnography, overnight sleep testing. Obstructive and sleep apnea and central sleep apnea occurred in 75% of patients on stable doses, significantly higher than the general population, and it is dose related, and it goes up with benzos being mixed in. So be very careful with patients with a history of significant snoring or patients whose respiratory rate drops on normal therapeutic doses. Long-term opioids also have hormonal effects. They reduce cortisol levels, increase prolactin levels, decrease LH, FSH, testosterone, and estrogen. Long-term opioids cause immunosuppression. So acute or chronic administration of opioids can inhibit antibody and cellular immunity, inhibit natural killer cell activity, can inhibit cytokine expression, can inhibit phagocytic activity. Endogenous opioids, as opposed to the ones we give, can actually cause immunoactivation. We may be suppressing this by exogenous opioids. Peripheral immune cells do release opioids, and they also have opioid receptors on them. Severe pain is immunosuppressive. So if you have a patient in severe pain, they're immunosuppressed. By giving them opioids, you may come out okay, because hopefully by having less pain, the immunosuppression of pain is going to go away, even though you're giving them immunosuppression of opioids. Opioid-tolerant rats are hyperalgesic. You see tolerance to the analgesia, so methadone, addicts who are being treated with methadone don't get analgesia from methadone. And opioid tolerance seems to be very similar to hyperalgesia, increased pain, an MDA-mediated effect. So when the patient experiences pain and glutamate is activating the second-order neuron, there's a series of events that go on with the activation of the NMDA receptor. There's increased or inflow of calcium, which goes back and feeds back on the NMDA receptors, making them more sensitive. And there's also feedback on the mu receptors, making them less reactive to the morphine. So NMDA receptors mediate a tolerance to opioids and a hypersensitivity, maybe even an hyperalgesia. Okay, let's go back to how we started this in the very beginning. We talked about how opioids have presynaptic and postsynaptic inhibition. And that was the classic picture of how great opioids were for treating pain for decades. In the last decade, the picture has changed, and we now add on this funny-looking thing, which is my symbol for the insulation of the cell, meaning the glial cells that surround the nerve cells. And it turns out that glial cells have receptors on them called the toll-like 4 receptor, and opioids bind to the toll-like 4 receptor on glial cells, activating the glial cells. And when glial cells are activated, they release inflammatory cytokines onto the nerves, activating pain and sensitivity. And we are flooded these days in the newspapers and on the media about the risks of opioids with overdose, with addiction, etc. I don't know about you, but in my practice, those arguments with my patients are completely ineffective. Right? The patient says, fine, but I'm not an addict. I don't overuse. Right? So they see no reason that what the media is saying applies to them. But this is different. Because I explain to them, when I'm giving you an opioid or when you're taking an opioid, yes, you're getting the short-term benefit of presynaptic and postsynaptic inhibition, but you're getting the long-term activation of your glial cells, making your pain worse. The analogy I use, I say it's like driving your car down the freeway with your foot on the gas pedal and on the brake at the same time. Right? You're braking pain here, and you're gas pedaling pain here. That's an argument that they can understand, okay, and may convince them to sort of work with you and be motivated to try to find other techniques other than opioids to treat their pain. Okay, so glial cells can be activated, releasing inflammatory mediators onto the presynaptic and postsynaptic nerves, activating both. What are the activators? Opioids is one of the key ones. There are lots of other activators. Opioids activate glial cells. Okay, so we may see a situation where a patient seems to have increased hypersensitive type of pain. And it's good for you in your mind, both clinically and test-wise, to think about the differential diagnosis for this situation. It could be that you're dealing with allodynia. It could be that you're dealing with opioid-induced hyperalgesia. It could be that you're dealing with opioid tolerance. I'll argue that these are very similar. And it could be that you are dealing with withdrawal. Okay, so think about how you would set these, differentiate amongst these. Allodynia you should be able to determine on a sensory exam. And typically you would treat it with neuropathic agents. It says here plus minus opioids. I would say usually without opioids. The opioids really probably don't make any difference in the short run, and in the long run probably hurt. Opioid-induced hyperalgesia, there's evidence it might be diagnosable with quantitative sensory testing, but most of us don't have that available. Decreasing opioids over time should help. Opioid tolerance is a clinical setting diagnosis. If you were to increase the opioids, you would see in the short run a benefit. Now, you probably wouldn't want to do that as your clinical decision, because it'll just be an ongoing cycle. And then withdrawal, during withdrawal, patients get hyperalgesic. Again, the clinical setting should make that clear. Slowing down the taper of the opioids will improve things. What about urine testing? Why would you do it? Well, first of all, you should know that urine testing is not the clear-cut way to avoid opioid misuse. There's some weak evidence that it does help. It is supported by lots of the state medical boards and the medical societies for its theoretical benefits. Estimates vary between 18 and 41% of chronic pain patients are abusing opioids. This might help you weed those out. And in general, some kind of monitoring of adherence to your prescriptions will decrease substance abuse and illicit use. You do have to remember the metabolism we talked about. Right? So if you give codeine to a patient, you shouldn't be at all surprised by the appearance of morphine in their urine. Hydro stay hydro, codones go to morphones. So again, you won't be surprised by hydrocodone showing up as hydromorphone in the urine. This one we didn't really talk about when we talked about metabolism, but there is a small amount of morphine that can become hydromorphone in the urine. So generally, it's small enough that you don't see it unless you're giving fairly high doses of morphine. It is true that several medications, including naproxen and ibuprofen, can give you false positives for cannabinoids. So you would have to talk to the testing lab that you're working with if their protocol for testing checks for this or eliminates this risk. Protonics can do it. No surprise that Marinol and Sustiva, because they are cannabinoids. Poppy seeds. Some evidence that 1 to 2 poppy seed bagels may have enough poppy seeds to show up as a false positive. And then there are other drugs here that can give you false positives. Dextromethorphan is an opioid. It's just a D-isomer. So I would strongly encourage patients to consider urine drug testing in all patients, especially new patients, but also periodically during their therapy. When you change therapies, when pain persists despite ongoing opioid therapy, or if you have any evidence of aberrant behaviors. Generally, it is a pretty cheap test. Many insurances cover. There's almost no reason not to do it. You're looking, by the way, for the drug that you're prescribing and its metabolites. So drugs you are prescribing should be present. Otherwise, the patient isn't taking, but you're prescribing. And you're also looking to see other drugs of abuse are not there. And again, you're looking also for the metabolite, which gives you some idea that they didn't just take it on the way into the office, but they've been taking it for at least hours to days. So the DEA and the CDC have tried to develop programs for risk mitigation. So they have this REMS program, Risk Evaluation and Mitigation Strategy for Opioids. It is required if you are going to prescribe short-acting fentanyl compounds. Okay, so the immediate release short-acting fentanyl compounds, the immediate release or short-acting non-fentanyl compounds, there's still no requirement for it. So when you take the training and then go through the test, to the REMS test, you have to score 100% on the test. You have to redo it every 2 years for it to be active. It basically says that you have to establish a patient-prescriber agreement and go over a medication guide with the patient. You are certifying that you're giving the drug for the treatment of cancer breakthrough pain. This basically means you cannot use short-acting transmucosal fentanyl for any other purpose other than breakthrough cancer pain, because you have to certify that's what it's for when you prescribe it. The REMS process is not required for inpatients or hospices or long-term care facilities. They are encouraging us to do this for long-term fentanyl or other opioids, but it is not a requirement. We're going to go through that. Almost every state, if I remember correctly, I think it's 49 states now, have some sort of prescription drug monitoring program. In California, where I am from, it is called Cures, but other states, give it other names. And basically, it's a methodology for prescribers to access a database to see what other prescriptions, controlled substance prescriptions, have been given to the patient, usually in 6 to 12-month range. Okay, we are done with opioids. We're going to take a deep breath and do a few slides on steroids, and then we'll take a break. You are about to perform a lumbar transforaminal injection on a 38-year-old male with a lateral disc protrusion. Which steroid would you choose? A, triamcinolone, because it is non-particulate and long-lasting. B, dexamethasone, because it is non-particulate. C, methylprednisolone, because it is long-lasting. D, betamethasone, because it is long-lasting and non-particulate. E, prednisone, because it is the most well-established steroid. Pick your choice. The answer is dexamethasone, because it is non-particulate. Dexamethasone is the only non-particulate injectable steroid. Particulate steroids injected into the spinal foramina are associated with a risk of embolic strokes of the spinal cord or brain. Okay, glucocorticoid receptors are present in the laminas 1 and 2 of the dorsal horn. Glucocorticoids have widespread systemic effects on bone, skin, muscle, fat, cardiovascular system, glucose, mental status, immune system. So lots of reasons to be careful about how you use them. They produce hypothalamic pituitary axis suppression and adrenal axis suppression up to 3 weeks after a single epidural and after 3 months after a series of injections. Embolic risk with arterial injection is what we were addressing with our question. So all the injectable steroids, except dexamethasone, are particulate. So whichever one you choose other than dexamethasone, you carry a risk of injecting emboli into a spinal artery. So you should not use particulate steroids for foraminal injections at any level. In many institutions, including mine, we don't use particulate steroids for any spinal injection, even midline. For glucocorticoids, they come in lots of different strengths, so this is a chart for you to be familiar with. I wouldn't say there's any reason to memorize this, but you should just be sort of aware that hydrocortisone and cortisone are among the less potent ones, with methylprednisolone, with all of these prednisone, methylprednisolone, and triamcinolone is sort of intermediate, and dexamethasone and betamethasone is potent. There are many times that you might want to consider giving a steroid pulse to your patients, typically orally. Very good for new onset or flares of neuropathic pain, and very useful for osteogenic pain, bone pain. So I just gave you a couple of different recipes here. This is a 18-day course. A methylprednisolone or Medrol dose pack is a 6-day course. So these are just a couple of standard recipes. This is what a dose pack looks like. Makes it a little easy for the patient to kind of know this is day 1, this is day 2, until you're down to day 6. Okay, we are 2